You wake up each morning, reach for your blood pressure medication, swallow it with a sip of water, and sit down to check your numbers on that familiar home monitor. The reading comes back 122/78, or perhaps 128/82. It looks perfectly acceptable. The little green light flashes its approval, just as it did yesterday and the day before. You feel a quiet sense of accomplishment. You are doing what the doctor ordered. You are staying on top of things. You tell yourself you are in control. But here is what almost no one explains. Friends, in those brief 7-minute clinic appointments. Right now, at this very moment, millions of people over 60 are following that exact same routine. They take their pills faithfully every single morning. They see numbers that look safe on paper. Their charts receive a check mark. Their doctors nod approvingly. Yet inside their bodies, something insidious is unfolding, something they cannot feel in the moment, something that will not appear on a standard sitting blood pressure reading until the damage has already progressed far enough to become difficult, if not impossible, to reverse. This is not because these individuals are careless. It is not because their physicians lack competence or compassion. It is because the entire conversation around blood pressure targets has been built on a foundation that quietly ignores one of the most fundamental truths of human biology after 60. Your body is no longer the same machine it was at 40 or 50. The arteries that once flexed and rebounded like supple rubber hoses have gradually stiffened. The brain that once received a steady, generous supply of blood now depends on a more delicate balance of pressure. The kidneys that filter roughly 200 liters of blood every day are working with narrower margins for error, and the number printed on your prescription, the number everyone is chasing, was calculated for a younger cardiovascular system that no longer matches the reality inside your chest. Let me be direct with you. If you are over 60 and you are actively managing your blood pressure with medication, there is a specific, well-documented, and potentially dangerous process unfolding right now inside your arteries, inside your brain, and inside your kidneys. It is not being triggered by blood pressure that is too high. It is being triggered by blood pressure that has been pushed too low for a body your age. And the most terrifying part is that it feels like absolutely nothing at first. Or worse, it feels like the ordinary annoyances of aging that we have all been trained to accept without question. You might notice a subtle morning dizziness when you first stand up from bed. You might feel a little foggy-headed before that first cup of coffee kicks in. You might find yourself instinctively reaching for the handrail on the stairs, even though you used to bound up and down without a second thought. You might hesitate for half a second before rising from your favorite armchair because something in your balance feels slightly off. You shrug it off. You tell yourself, this is just what getting older feels like. You move on with your day. It is not just what getting older feels like. By the end of this video, you will understand exactly what that subtle discomfort really is. You will understand why it is happening. You will understand the biological mechanisms at play with a level of clarity that most 7-minute doctor visits simply do not have time to provide. And most importantly, you will know the precise 3 questions you need to bring to your next appointment. The questions that could literally change the trajectory of your health for the next decade or more. My name is Dr. Hidden Stories. I am a nephrologist and hypertension specialist who has spent my career focusing on the unique cardiovascular realities that emerge after 60. The question I'm answering today is the one most patients in this age group have never thought to ask. Not, what is my blood pressure right now? But, what should my blood pressure actually be for a body my age, with arteries my age, and a brain and kidneys that depend on adequate pressure to stay sharp, stable, and functional? The answer is not automatically 120/80, and I can prove it with the science, the physiology, and the real-world outcomes I see in practice every single week. There is a concept in cardiovascular medicine called the J-curve effect. It may be the single most important thing you need to understand about your health right now. Yet, it is rarely explained in routine appointments because there simply is not time. We are going to unpack it thoroughly here because every section of this conversation builds directly on the last. The part that will fundamentally change how you think about every future blood pressure reading you take is coming in the middle. Stay with me, the context matters. To appreciate why the number on your prescription might be quietly working against you, we first have to examine where that number actually came from. The history is more uncomfortable than most people realize, and it reveals a systemic blind spot that has persisted for decades. The classic 120/80 standard that still dominates so much public conversation was not discovered through large-scale, long-term studies focused primarily on older adults. It was built largely on research conducted in middle-aged populations, people in their 40s and 50s, whose arteries were still relatively elastic and resilient. Those findings were then extrapolated across age groups as though human biology remained static from age 45 to 72. It does not. Biology changes dramatically. The original logic was sound for the population it was tested on. Lower blood pressure reduces mechanical strain on vessel walls. Less strain means fewer micro tears, less plaque buildup, fewer heart attacks, and fewer strokes. For a healthy 48-year-old with flexible, youthful arteries, pushing numbers downward was clearly protective. The evidence was robust. Lower in that context was unequivocally better. But after 60, your arteries undergo a predictable, age-driven transformation that is not a disease, but a fundamental shift in physiology. Collagen fibers accumulate and cross-link within the vessel walls, making them thicker and less compliant. Calcium deposits form gradually along the inner linings. The smooth, endothelial layer that once expanded and contracted effortlessly with every heartbeat begins to lose its elasticity. What was once a flexible garden hose capable of absorbing the surge of each cardiac contraction now behaves more like a rigid pipe. A rigid pipe requires higher driving pressure to maintain adequate flow, especially when that flow must travel upward against gravity, all the way from your heart to the delicate vessels at the top of your brain. This is documented, normal aging physiology. Yet when modern medicine takes a blood pressure target designed for elastic, middle-aged vessels and applies it without adjustment to stiffened, older ones, the consequences are real, they are measurable. And in far too many cases, they are irreversible if allowed to continue unchecked. The 2025 joint guidelines from the American Heart Association and the American College of Cardiology recommend a target of below 130/80 for most adults. That recommendation reflects strong population-level evidence from massive trials. I use those guidelines every day as my starting point. But there is one critical word buried in the language that almost no patient ever reads carefully. The word is most, not all. Because for a significant and growing portion of adults, over 60, particularly those who are even mildly frail, who have a documented history of falls, who show signs of arterial stiffness, or who already experience dizziness or mental fogginess when they change position, pushing aggressively toward that lower target creates an entirely new and different set of problems. Problems that the research conducted on younger patients was never designed to detect. Let me illustrate this with a story that is representative of what I see repeatedly. I will call her Margaret. Margaret was 71 years old, a retired school teacher who had always prided herself on her organization and discipline. She walked every single morning, prepared her own meals from scratch, attended every medical appointment without fail, and followed every recommendation to the letter by every conventional metric. She was the model patient doing everything right. Her blood pressure had been hovering around 148/84. Following current protocol, her primary care physician added a second antihypertensive medication to bring the reading down toward the 130 target. 6 weeks later, her numbers sat comfortably at 118/72. The doctor was pleased. The chart looked excellent, but Margaret did not feel excellent. She came to see me because she could not quite name what was wrong. Every morning she woke up feeling foggy, as though her thoughts were moving through molasses. She had nearly tripped on her front step twice in 2 weeks. She felt lightheaded the instant she rose from her armchair. She had quietly stopped her beloved morning walks because she no longer trusted her own legs on the uneven pavement. 3 different doctors had already reassured her that these sensations were simply normal aging. When I performed the simple lying to standing blood pressure test that takes less than 3 minutes, her systolic pressure dropped 24 points. That is the clinical definition of orthostatic hypotension. Her brain was being briefly starved of adequate blood flow every single time she changed position, because no one had ever performed that specific measurement during her routine visits. The problem had remained invisible on every standard chart. We worked carefully with her own physician to adjust the regimen. We shifted her target to a range that respected the actual biology of her 71-year-old arteries rather than the population average of someone 2 decades younger. Within 2 weeks, the mental fog lifted. The dizziness disappeared. She resumed her morning walks. At her follow-up visit, she said, "The number on the machine looked better, but I felt like I was disappearing. I genuinely thought that was what getting older was supposed to feel like." It was not what getting older was supposed to feel like. It was the wrong target applied to the wrong body at the wrong time. Now let us go deeper into the biology, because understanding the why is what empowers you to have a different conversation with your doctors. This is the part that changes everything. When researchers plot cardiovascular risk against blood pressure levels on a graph for older adults, the expected straight downward line does not appear. Instead, risk falls as blood pressure decreases from dangerously elevated levels. But then, below a certain individualized threshold, the curve bends upward again. The graph literally forms a J shape. This J-curve effect has been replicated across multiple large-scale studies. One major analysis focusing on elderly patients over 60 found that cardiovascular mortality risk associated with low diastolic blood pressure became statistically significant once diastolic numbers fell below approximately 70 millimeters of mercury. The mechanism is now well understood. During diastole, the resting phase between heartbeats, the coronary arteries that supply the heart muscle itself receive the majority of their blood flow. If diastolic pressure is pushed too low by medication in an already stiffened arterial tree, the heart muscle begins to experience relative underperfusion during its own recovery period. It is not enough to cause an immediate heart attack, but it is more than enough to allow subtle ischemic damage to accumulate quietly over months and years. Arterial stiffness is the critical missing piece that most routine blood pressure conversations entirely overlook. In younger adults, the aorta and major arteries act as a natural buffer. They expand to absorb the surge of blood ejected with each heartbeat, and then recoil elastically to maintain steady pressure during diastole. In older adults, the recoil weakens. Systolic pressure rises because the rigid walls cannot absorb the surge. Diastolic pressure falls because there is less elastic return to sustain flow between beats. The result is a widening pulse pressure, the gap between the top and bottom numbers, and that widening gap is one of the most reliable markers of vascular aging currently known to science. When antihypertensive medications, most of which are designed primarily to lower the systolic number, enter this already altered system, the balance can shift dangerously. Diuretics, beta blockers, calcium channel blockers, ACE inhibitors, and certain combinations of these drugs can push diastolic pressure into a zone where coronary perfusion is compromised. Cerebral blood flow on standing becomes insufficient, and the kidneys, which require consistent pressure to filter 200 liters of blood daily, begin losing function in ways that produce no obvious symptoms until the damage is advanced. The kidneys are exquisitely sensitive to perfusion pressure. Even modest reductions in effective blood flow can trigger compensatory mechanisms that, over time, lead to glomerular damage, protein leakage into the urine, and a gradual decline in estimated glomerular filtration rate. Many patients who believe their kidneys are fine because their creatinine looks normal on a basic panel, are actually experiencing silent progression. The brain is equally vulnerable. Multiple studies have established a direct link between arterial stiffness, reduced cerebral blood flow, and accelerated cognitive decline. When stiffened arteries fail to deliver consistent perfusion to the brain's smaller vessels, white matter integrity begins to deteriorate. Executive function slips. Processing speed slows. Short-term memory becomes unreliable. Because these changes occur gradually, both patients and physicians often attribute them entirely to normal aging. A significant body of evidence suggests that a meaningful portion of what we label as cognitive aging after 60 is actually vascular in origin, and a substantial slice of that vascular damage is driven by blood pressure levels that have been lowered below the threshold a stiffened cardiovascular system can safely tolerate. This is the pivotal section. Before I give you the practical numbers and the exact 3 questions you need to take to your doctor, I want to ask you something directly. When your doctor measures your blood pressure during a routine visit, do they ever take the reading while you are lying down and then repeat it immediately after you stand up? Yes or no? Leave your answer in the comments below right now. In my clinical experience, the overwhelming majority of patients over 60 have never had that simple 2-position orthostatic test performed in a single appointment. Your answer will help shape exactly what I cover in future videos. So what blood pressure range should you actually be aiming for after 60? The honest answer is that it depends on who you are as an individual. For most active, independent adults between 60 and 75 with no significant falls history, no documented frailty, and no dizziness on standing, the American Heart Association and American College of Cardiology target of below 130/80 remains supported by strong evidence. Landmark trials such as SPRINT and STEP, along with multiple large meta-analyses, confirm that reaching this range reduces stroke, heart attack, and cardiovascular death in that relatively healthier subgroup. But for adults over 75, or for any adult over 60 who experiences dizziness or lightheadedness upon standing, who has had even one fall in the past year, who shows signs of frailty, or who has noticed subtle memory or cognitive changes, the picture becomes significantly more nuanced. Guidelines from the European Society of Hypertension recommend a systolic range of 130 to 139 for adults 65 to 79 and permit 140 to 150 for those over 80 or for frail individuals. That higher range is not a concession to inadequate treatment. It is biology-appropriate medicine that respects what a stiffened arterial system actually requires to deliver adequate perfusion without triggering orthostatic crises. The single most important number that most patients over 60 have never been taught to track is not the reading on the machine in the clinic, but it is the difference between your lying down reading and your standing reading. A drop of more than 20 points in systolic pressure upon standing meets the clinical definition of orthostatic hypotension. This condition affects between 10 and 30% of older adults. Research involving more than 49,000 individuals has shown it carries a 73% higher risk of falls, and a fall in this age group is never minor. Hip fractures alone are associated with a 5-fold increase in 1-year mortality. Here is what I want you to write down before this video ends. 3 precise questions that you should bring to your next appointment. Question 1. Can you measure my blood pressure first while I am lying down, and then again immediately after I stand up to check for orthostatic hypotension? That test requires less than 3 minutes and detects the very problem that no sitting-only reading will ever reveal. Question 2. Given my specific age, the health of my arteries, my symptoms, and my overall frailty status, what blood pressure range is truly right for my individual body rather than the population average? Question 3. Looking at my full medication list together, could any of my current drugs, or any combination of them, be contributing to dizziness, lightheadedness, or cognitive fog, orthostatic hypotension in older adults, is frequently caused or worsened by medications. Your entire regimen deserves a holistic review rather than isolated adjustments. Margaret returned to see me 4 months after we adjusted her treatment. She had not fallen once. The dizziness on standing had vanished completely. She was walking 45 minutes every morning again along the same route she had followed for years. The cognitive fog she had quietly accepted as the inevitable price of aging had lifted entirely. Her blood pressure now read around 100, or 38/76, not 118, but the right number for her particular body, her 71-year-old arteries, and her still functioning but age-adjusted cardiovascular system. She looked at me and said, "I spent 2 months feeling like I was disappearing, and I truly believed that was just what getting older was supposed to feel like. Too many people over 60 are living quieter, diminished versions of their former lives. They feel less sharp, less steady, less certain on their feet. They attribute every bit of it to age. Some of it is indeed age, but a meaningful, measurable, and often reversible portion of it is the result of a blood pressure target that was applied without stopping to ask the right questions or perform the right tests. You are not supposed to feel foggy every morning. You are not supposed to grip the handrail on your own stairs as though it might save your life. You are not supposed to hesitate before standing up from a chair you have sat in 1,000 times. These are not the inevitable taxes of living past 60. They are signals, and now you know what those signals may actually be telling you. Let me bring everything together with complete clarity. The real truth about blood pressure management after 60 is this. The classic 120/80 standard was constructed primarily from data on middle-aged adults. It remains a reasonable population-level starting point, but it is not automatically the correct target for every individual over 60. After 60, the natural stiffening of arteries changes what your cardiovascular system fundamentally needs. Arteries that can no longer recoil elastically produce lower diastolic pressure as a matter of course. Aggressive medication that pushes those numbers still lower can deprive your coronary arteries, your brain, and your kidneys of the perfusion pressure they require to function optimally. The J-curve effect is real, replicated, and clinically significant. Even below a certain diastolic threshold, especially in older adults who already have some degree of coronary disease or arterial stiffness, cardiovascular risk does not continue to fall. It rises again. Orthostatic hypotension affects up to 30% of older adults and is associated with a dramatically elevated fall risk. It is almost never detected unless a clinician specifically tests for it with a lying to standing measurement. Ask for that test by name. For most active adults aged 60 to 75 with no frailty or dizziness, the below 130/80 target is well supported. For adults over 75 or anyone with frailty, a history of falls or symptoms on standing, a higher individualized range, guided by a physician who understands your complete picture, may be not merely acceptable, but medically essential. Take the 3 questions I gave you, write them down, bring them to your next appointment, use them. They are your bridge to better, more personalized care. I genuinely want to hear from you in the comments section below. Have you ever experienced dizziness, mental fogginess, or unsteadiness, and simply assumed it was normal aging? Has your doctor ever measured your blood pressure in both lying and standing positions? Leave your answer. I read every single response, and what you share genuinely helps shape the topics I cover next. If this conversation gave you new insight or a sense of empowerment, please share it with someone in your life who is over 60, who is faithfully taking their medication every morning, whose numbers look fine on paper, and who has no idea that fine on paper may not mean fine in actual daily living. Subscribe if you want to continue these honest conversations about health after 60. In the next video, we are going to examine the 5 blood pressure medications most commonly prescribed to older adults, and the specific cardiac, cognitive, and renal side effects that almost no one is warned about at the time the prescription is handed over. One final important note. Everything I have shared today is based on current published research and my clinical experience. Your situation is unique. Your medications, your medical history, your physiology, and your personal risk factors are yours alone. Do not adjust or stop any medication based solely on what you heard here. Bring the questions, the knowledge, and the context to your own physician. That informed, direct, and unhurried conversation is exactly where the best medicine begins. This is Dr. Hidden Stories. Stay informed, stay empowered, and take exceptional care of the body that has carried you faithfully every single day of your life. I will see you in the next one.